Alright, so the August CEUs is over CNS injury, and the majority of that, it wants you to go over a neuro assessment, and then the majority of it is spinal motion restriction protocol. So we're going to cover both. I passed out a piece of paper if you're interested in the data on spinal motion restriction and why we switched to it. It's been a protocol for quite a while, but probably maybe your most misunderstood protocol that there is. So we're going to start with neuro assessment, and then we'll talk about spinal motion restriction. If you haven't signed the 1085 that's on the table there, make sure that you do so you get credit for the class. So neurological assessment, if you have a CNS injury, it starts with AVPU. That's where AVPU comes in, is alert, verbal, painful, and unresponsive. So we assume that the person is alert if they're alert for this. Once we determine that they're alert, then we go, are they alert and oriented times 4, and is their GCS 15? Okay. Then your next kind of question to yourself is, was there ever a loss of consciousness? Kind of your 3 initial things when I walk up. Is this person alert still? Are they NO times 4, GCS 15? And then, hey, were you knocked out at any time? And that kind of starts my general first impression to know what I'm looking for is life threats. Okay, so if I walk up and the person's alert to verbal and they're not oriented, they're ANO to 0, and they obviously were knocked out and is now back awake, we should start thinking about they may have a head injury that's a life threat. Does that make sense? Once we get through those first initial questions, then we go to a head and toe assessment. So I just put a whole bunch of different stuff up here. This is actually a textbook assessment straight out of the book to give guys a kind of head to toe ideas of stuff to do. You don't have to cover every single one of these every time, but it's just kind of general questions. Do they have a headache? Are they dizzy? Have the feeling of lightheaded, being lightheaded, right? Starting at the top. And then vision problems. Is their vision blurred? Can they track you when you're talking to them? If I'm talking to them in the ambulance and I'm moving from the back of the cot to the front with my IVs, are they tracking me while I'm speaking to them, or are they just staring at the back of the ambulance? They may say my vision's fine, but they're not tracking me like they're supposed to be. Signs of a problem. What their pupils look like. Is one much bigger than the other? That's a very good sign. This can also throw you off. If you get hit in the eyeball, that pupil will restrict. This is a big thing in fighting. That's where I know this from. It's a big thing you look for in the corner when you're looking at your fighter. Is his pupil still okay every time? If one of them is blown up, one of them is tiny, it's time to stop the fight. Guy's got a bad concussion. Okay. This can also, from an eye poke, can have this happen too. So it can throw you off. But very good sign is one pupil being bigger than the other. Are they still reactive to light? Are they both blown super huge? Are they both pinpoint? Kind of what's going on. Next is speech. Obvious. Pretty obvious, right? Can they speak clearly? Is their speech slurred? Do they have, what did you say earlier? Word salad. Do they speak with word salad, right? They just blurt a whole bunch of stuff to you. Are they repetitively saying the same thing over and over and over again? I saw this one time on a wreck. A guy fell off a motorcycle, hit the back of his head, and he would just say the same sentence again and again. And I was like, oh wow, that's repetitive statement again and again and again. All right. Moving down from there, C-spine palpation. Okay, so we'll talk about this on whether or not we need spinal motion restriction. So what we're looking for on the C-spine is palpating their C-spine, the posterior C-spine straight down the spine, right? Not their entire neck, not the front of their neck, their actual C-spine, finger by finger down the back, and I'm looking for step-offs with my fingers or feelings of things moving around, like crepitus, right? That's what I'm feeling for. And then I'm asking them if anything hurts, and I'm watching them to see if they grimace. Okay, why do you do that? Okay, a lot of people say my neck feels fine, but then when you touch it, they, okay, there's an injury there. Right? What we're not looking for on C-spine palpation, this is not your C-spine. Your muscles of your neck is not your C-spine. Your trachea is not your C-spine. Right? Pain along your collarbone right here is not neck pain. That's chest pain. Okay, so we're looking for C-spine pain. Erratic breathing patterns, moving down to your lungs. Right, so head injuries cause several different types of erratic breathing patterns. If you see the patient's breathing some weird way, right? Super fast or erratically, where the deep breath, bunch of short breaths, deep breath, bunch of short breaths. Okay. Lots of different ones, but you'll be able to notice all of them. They're just not normal. It really doesn't matter what type of breathing pattern they're using. It's just their breathing's erratic, and it's not like it should be. Next is spine palpation. So the same thing on the C-spine, moving down the rest of the way, all the way down. Same thing, feeling for things that are out of place. Suddenly their spine goes 3 inches to the right or the left, or there's nothing there anymore. There's a hole. It's called a step off, right? Or that they're grimacing when you're pushing on it, or they're telling you that it hurts. Okay, the exact same thing. This is not your spine. Okay, this is your ribs, not your spine. Okay, you look for pain on the spine itself, or in what's called the paraspinal region, which is right? Paramedic extension of a doctor, right? Extension of your spine, the direct area that's around your spine. That's what I'm looking for. Grips. As we get them moving down their back, we move out to their extremities. Can they grip my fingers? Can they move all their fingers and their toes? Right? Can they tell me if I say move your right hand, do they know their right hand, their left hand, their right toes, their left toes? Okay, the one I like the best is use it, make them touch their fingers. Ask them to do this. Takes complex neuro to do this. If you can hold your hands up and do this, you're with it. Okay? Neurologically, maybe not mentally, but neurologically, you're with it. Right? You can, if I hold my finger out, can you touch my finger with your finger? That shows that you can do the cool word down here, spontaneous and coordinated movements. Right? This tells me your brain's working correctly. Numbness or tingling. Okay, numbness and tingling, the hands can indicate anxiety, right? Which is common after a car wreck, my hands, breathing pattern, right? It also can indicate injuries to your neck. Like I said, spontaneous coordinated movements, we can direct them to do that, or we can also just watch them do that. They're moving around on their own, they're getting their cell phone out. Okay, you don't have a C-spine injury, at least not a serious one. If you're digging into your purse and getting your cell phone out, calling your husband, okay, you're good. And then the worst there, obviously, is posturing. That's the big one as far as bad injuries go. If they're decorbrate or what's the outside? Cerebrit, right? Doesn't matter which one. No, they have a really bad band injury, they're posturing, right? Okay, so head and toe assessment for a neuro injury, right? So just kind of, every assessment's the same way. I walk up and I get a general idea what's going on. I'm looking for a life threat, and then I'm doing a detailed assessment to find a symptom. When I find a symptom in the assessment, I treat that symptom, right? So the symptom was C-spine pain for this one. I have posterior C-spine pain during palpation, okay? So those patients kind of come to this. Do they need spinal motion restriction? Okay, so we're gonna talk about this. Move into it real quick before we get into that. The difference between spinal motion restriction versus spinal immobilization, okay? So back in the 60s, they came out with spinal immobilization. They said, we're gonna take patients, anybody that's had a mechanism that could have possibly hurt their back or their neck, and we're gonna prevent them by being paralyzed by strapping them to a backboard, put them in a C-collar, and strapping their head down head blocks, okay? They studied this for a long period. They didn't study it for a long time, we just kind of did it. And then starting 2016, 2018, a couple studies, one of which I gave to you guys, they said, hey, this doesn't make sense. What we're seeing is that we have a lot of injuries, pressure ulcers, a lot of pain from riding on the backboard, and then the majority of these patients, if not almost all of them, don't have a C-spine injury. Okay, so we're just kind of doing this because it's what we've always done. So they said, we shouldn't do this anymore. We have a theory that if you look at the spine, okay, so you look at a backboard is straight like this. You look at the spine, that's not the same, okay? So we're putting this person on there and immobilizing them on a surface that is not like their spine. So if we do actually immobilize them, we're gonna hurt them, okay? So they went to spinal motion restriction. I said it's much better if you immobilize them and try to reduce the amount of movement to their spine, okay? So if they have C-spine pain, they're gonna end up with a C-collar, and they're probably not gonna end up on a backboard, okay? And then they tested this for a couple years, okay? So 2018 is when the big push came out, and that study has it in there. Essentially, no one was harmed by this. Okay, what they do have is a lot of proof that spinal immobilization hurts people, and almost none that spinal motion restriction is bad for you. Okay, they can't really find a single case. And what they said is that basically we don't really deal with people that have injuries that are so unstable that us putting them in a backboard and a C-collar would do them any good. That it would be the difference between paralysis and non-paralysis. Okay? If you're hurt that bad, the movements getting you out of the vehicle and extricating you are probably going to damage your spine. There's not a whole lot we can do about it. So they recommend that you move this because it doesn't do any more harm. Okay? Well, starting with who needs it. Okay? So do they need it? Straight out of the protocol, I just adapted these bullet points to make it easier. Okay, so who needs it? Okay, the person, are they A0 to 4 GCS 15? If they're not, then we can't believe what they're saying. They're a poor historian. We're going to put them in spinal motion restriction. Are they intoxicated? Do they have to be sober? Or they have to be a reliable historian, right? Do they have a neural deficit? And we find neural deficits in this. If they have a neural deficit, they're getting spinal motion restriction. Okay? Do they have a distracting injury? Like their back pain is hurting. Maybe it's not right where I want it to be, but it's hurting so bad that they can't stop moving. You're gonna have to put that person in spinal motion restriction. Okay? Were they in a high risk event, like being thrown from a car, falling through the roof of Walmart, something like that? We're gonna kind of assume we're gonna put that person in spinal motion restriction. And there's the big one, posterior C-spine pain upon palpation. Okay, so I need to be able to detect posterior C-spine pain. As I said before, not anterior, not close to the neck, not the top of the head, but posterior C-spine pain. And then, can they rotate their head 45 degrees? Okay, if they're in the car and they're talking to you at a 45-degree angle, they do not need to be in posterior in spinal motion restriction. They're spontaneously moving their head around. If they had a C-spine injury, it already would have damaged their spinal cord. Okay, so if they're in the car talking to you, moving around everywhere, they don't need to be in. They can rotate their head 45 degrees. So we decided to put them in spinal motion restriction. What does that mean? Okay. The protocol, our protocol currently gives you a little bit of leeway, okay, because it's a newer version of it. If you read more into this, such as that one there, it'll tell you basically never use a backboard again. Okay, we're not there yet. It still gives you a little bit of choice. So it says you should apply a C-collar, right? It needs to be appropriately sized. And I'm going to go over that here in a little bit on how to size them, how to put them on. Always avoid traction. The main problem with C-collars is that they're almost always too big, right? So we go necklace on a lot of people, and then you put them on, and then you traction their neck. If you traction someone's neck with a C-spine injury, you're going to hurt their spinal cord. Okay, so you could do just as much damage putting a C-collar on as you're trying to prevent, especially when you put it on very quickly and you're not paying attention to how big it is. And you're like, hey, move your head for me so I can get the C-collar around. We've all heard this at some point. The person's like lifting their neck to get that thing under there. If they had an injury, you aggravated it, right? Roll the patient to a backboard, a scoop sketcher, or the cot. And you see in parentheses, the cot is preferred. So the cot has a built-in backboard. The cot has a solid metal plate that is underneath the padding. Okay, so modern backboards, the best backboards that are made for this, they're not flat plastic anymore. They're like the ones we still carry. Okay? They have pads on them and they're naturally curved to look like a spine, like a human body looks. Okay? So the cot does that by the pad. It has a built-in backboard and it has a pad top to it. The cot doesn't cause you as much pain. The cot doesn't cause pressure ulcers, etc., depending on how long you're on there. Okay? So they prefer that you use a cot. The thing about the cot is you're going to need a good way to move that person once you get to the hospital besides a blue sheet. You can't really control their head on the blue sheet. So you're going to need to put some type of stretcher on there, okay, like a Mega Mover or one of the orange sliding sheets that we have underneath, right? Those work really good to move people. You can use a blanket. There has to be something underneath them, right? Preferably, you're using a Mega Mover or a device that was approved to lift, not a blanket. A blanket's not an approved lifting device. So if it rips because we bleached it like 50 times and they fall, that's on you. Secure heads with head blocks, okay? So you can secure them directly to the cot, you can secure them to the backboard, to the stretcher, right? You can secure them to the Mega Mover. They just need to not be bouncing around, right? It's not achievable to immobilize someone's head with head blocks. You're just trying to minimize it. And then secure them with all straps. This is the big one. At some point, we've all done this, where we take them, we put them on the backboard, we strap them all down. You're like, this is the greatest spinal immobilization of all time. And then we put them up on the cot, and then we strap them on and we leave. because the straps are on the backboard. And then the backboard is sliding all over the cot because it's not strapped to the cot. Or we mix and match which straps go to which. You guys ever seen this? You've got a cot strap to a backboard strap, and they're mix and match. The patient's moving all over the cot. Whatever immobilization you had, you lost as soon as you left the transport. So you've got to make sure that the backboard, if they're on a backboard or if they're on the cot itself, they are secured with all the straps to the backboard so it doesn't slide around. So how do you extricate somebody? This is where I can see Mickey squirming. Okay, this is the old school, right? How do you extricate somebody without a backboard? Mickey likes to extricate people with backboards. I'm picking on him. But it's great. It's a great extrication tool. Okay, and it even tells you in there it's a great extrication tool. Don't stop doing it. You just notice at the bottom it says don't leave them on there. Okay? So you apply a C-collar. This is very much how pretty much everybody's done it for the last 20 years, right? You apply a C-collar, right? And when you need a backboard, especially when they're in the seat and they're smashed in there, right? You stick the backboard under them, you roll them, and then slowly lay them down the backboard, bring them out. Still the way they want you to do it, okay? Use it when you're needed. If it's not needed and they can self-extricate, let them self-extricate. Because a person with an injury and a C-collar will protect their own injury. Just coach them, put the C-collar on. Hey, you can stand up. I understand your neck hurts. Step out, stand slowly, and sit down. That's much safer and less movement than rolling them off the backboard and dragging them out of there, right? So if they can self-extricate, let them. Always have them sit, then recline. Okay, don't take somebody. Okay, so what they mean by that is don't lay the cot down flat. Have them sit on the cot and then fall down to the cot. That's a lot of movement that you can't control. So if they have a neck injury, you're going to navigate it. So always sit the cot up, have them sit on it, and then slowly take them back to recline. Make sense? Kind of common sense, but when we're in a hurry, we forget sometimes. If you do use the backboard to remove them, they want you to remove the backboard. Okay? This is where the protocol is not clear. They gave you an option to use the backboard, but then they tell you if you extricate somebody to remove it. What eventually you'll see is this be taken out, and it'll be what the American College of Emergency Physicians want, and it says no more backboards. Okay? But we're not there yet, so you still have the option. The protocol says remove the backboard, but it also says you can use it. So as of right now, you're allowed to pick. If you don't want to remove the backboard, you don't have to, but it is recommended in the protocol that they are not transported on the backboard. Transport on the cot. The main thing out of this in the end is the don'ts of this, okay? And don't do standing takedowns, okay? They're dangerous and they've never helped anybody and they probably hurt a lot of people. Okay, don't put a backboard on somebody and strap them on and stand them down to the ground. Don't do that. That's really bad for you. You do not need to put everybody with penetrating trauma on a backboard. It's actually shown, when we're talking about shootings, stabbings, car wrecks for people impaled, it's showing that it's dangerous. Okay? C-spine injuries and all spine injuries, they're caused by blunt trauma, not penetrating trauma. Okay, so don't penetrating trauma, shooting, stabbing, etc. Don't need a backboard. And then do not routinely transport on the backboard. It should not be your go-to. That should not be the routine. Okay, so what this is saying, if you read into this, what this wants you to do is use a procedure and decide, I'm going to transport this person on the backboard because I think it's in their best interest because I found this. It does not want you saying, this mechanism says they need to be on the backboard, so I'm going to take the guy that's standing in the field like this talking to you on the motorcycle crash, make him lay down onto the ground onto a backboard, immobilize him, and then put him on a cot and then have him bounce for 30 minutes to toss on a backboard. Okay? If you really think about immobilization, even if that's what we were still trying to do, but we're not anymore, we just want to restrict the amount of movement there. That doesn't make sense, and it never did. And that's what the studies kind of show that we've proved. Okay? So that's what the protocol says. You should be choosing, you should have a good reason. Like, I think this person has a spinal injury because of these symptoms. I extricated him from the vehicle, and I decided that it would be too much movement to remove the backboard. So we left them there. And then I transported them to Tulsa. That's a good reason to leave the backboard, right? Or I had to transport this person out of this field they were ejected into and they were on the ground. So I moved them on the backboard and got them there, and I decided to transport them. That'd be a good reason. But you should not be routinely doing it because it's just what you do, because that's not what you do. okay? Such as using the backboard as a full body splint, right? They would rather you put that person on a mega mover, put that person on the cot, and then splint the injuries they have. Because if they do have a C-spine injury, the backboard can do damage to it because you're bouncing on it. Does that make sense? So no more spinal immobilization, and that is spinal motion restriction. There's probably a lot of questions about this that are out there because the protocol is unclear and it makes you have to read through and kind of put it together. But